Welcome to the Language Testing and Certification Program's Ethics Training in alignment with the DSHS Code of Professional Conduct. I would like to welcome Linda Golly and Ileana Lobo, your presenters.
Welcome, everyone. We look forward to a wonderful orientation session with everyone today. Our training objectives are: we want you to be able to describe what a code of ethics is. What does that mean? Why does every health profession have a standard of ethics, a code of ethics? What is it good for? In particular, what does our code of ethics cover? As medical interpreters, what are we required to do and expected to do? We're going to use a lot of personal stories about true situations. We're also going to bring up hypothetical situations to challenge you to think about what you would do in certain situations that tend to come up pretty frequently for us. And here are some examples. What do you do when you are asked to perform beyond your scope of practice? What do you say? How do you say it? What do you do if the patient calls you at home to get your medical advice and wants a ride to the next appointment? What do you do if you really do not understand what that DSHS representative is saying, but the client expects you to be very knowledgeable? What do you do if the care team asks you to tell them what the patient said to you in the waiting room? What's the right thing to do when the family with a new baby tucks a gift in your briefcase? What happens when you make a mistake and you realize it a few minutes later? How about if your sister runs a store with ethnic remedies that you think would be just a fabulous thing for your patient? How about if you interpret for a person that you strongly disapprove of based on that person's personal choices? Or how about if you could make a lot of money interpreting for your extended family and close friends? We're going to be looking at lots of stories like this. We're going to be going over the different elements of the DSHS Interpreter Code of Ethics. For each point, we're going to talk about what it really means. We're going to pose some hypothetical situations, and we are going to ask you some quiz questions and walk you through the quiz. We have tried to make quiz questions that reflect our everyday reality. You're not going to have to take a quiz while you're listening to this orientation, but you will be taking a quiz shortly after you take the presentation, after you go through this orientation online, and you will turn those answers back into the DSHS LTC program. The questions that you will have on those actual formal quizzes will be similar, but not the same as the ones that we use during the orientation.
Thanks so much, Linda. This is Ileana Lobo. And I just wanted to review briefly what in general is a code of ethics. We know that there's many professions that have a code of ethics: doctors, lawyers, social workers, even airline pilots. How does that apply to us as medical interpreters? Well, a code of ethics basically, fundamentally, is a code of behavior or set of rules. And these codes of ethics are tailored or standardized for specific professions that reflect the types of responsibilities and job functions that these professions carry out. So everyone within a specific profession or performing a specific function, say in a medical laboratory or research facility, they're all supposed to follow their particular set of rules. The code is usually set by people who live by it and whose reputation it defines. And a code of ethics describes correct conduct in a specific role.
So, Eliana, question for you. We take care of patients. So, is it important that we do it in a certain way? Is what we do any different from selling shoes? Why would we have a code of ethics? And maybe somebody who sells shoes does not have a code of ethics.
Well, the easiest way to encapsulate that answer is patients first and patient safety. Shoes may have some wear and tear, but ultimately people aren't distressed if their shoe comes to harm the same way as a family member or friend or even their own self comes to harm. So these codes of ethics are there not only to protect patients, but also to protect the people that provide service to the patients. So here are some other industries and other professions that adhere to a healthcare code of ethics. In general, doctors, nurses, pharmacists, therapists, people that work in hospitals and medical clinics, even the student healthcare clinic, All Health at University of Washington, all have to adhere to codes of ethics. They're there to protect patients from harm, to disseminate correct information for good health outcomes, to provide financial safety from predators that would choose to prey on people in this moment of stress and weakness, and helps maintain privacy, which also empowers the patient to feel safe and partner with their healthcare provider and adhere to their recommendations so that there is a good health outcome. It also clarifies the role of the worker, giving you some do's and don'ts. So, for example, what is the scope for my profession? What lies within that scope and what lies outside that scope? So what am I supposed to do and what should I try not to get involved in?
So, Eliana, if you are a nurse and I ask you to do brain surgery, would the code of ethics help give you guidance on that?
If you asked me as a doctor to do brain surgery when I'm a nurse, I would seriously consider having a chat with the doctor to request some vacation time. These rules and regulations are there specifically to keep job responsibilities within the realm of the people that have been trained and credentialed and verified to be able to carry that task out safely. And for that reason, also the certification that's specific to the state of Washington is important to have. You may have a sister or a brother or an in-law that is a nurse in another state. But if they're visiting someone in the hospital here and the nurse comes in and says it's time for your heparin shot, that family member or friend can't say, oh, I'm a nurse in New Jersey, I'll give them the shot. It just doesn't work that way. You have to be a bona fide, educated, trained, vetted, and certified person to perform that task in the state of Washington. And every state has their own rules. So if somebody wanted to assist with their family member's care, that would be something up to them to undertake the training, take the tests, get certified, and then be assigned perhaps as their home health care worker, but not just because they do it somewhere else. And that also applies for interpreters. It applies for any training and interpreting that you've done outside of the state of Washington, or if you've worked in other areas like interpreting in the schools or interpreting in the courts. You may have education, preparation, training, and certification, but unless it's medically specific, it's not going to qualify you to work in most of the King County hospitals, major medical centers. So, again, having these code of ethics clarifies the role of what the worker is expected to do. What is the scope? What's within, without that scope? And what are the professional boundaries, both for relationships with coworkers and the relationship that you have for the patients and the families you interpret for. And it also helps clearly define a superior worker's performance and separate that from an average worker or a not-so-good worker's performance. So that helps in your performance assessment in figuring out the quality of your work. Is it high? Is it medium? Is it low? And it helps instill the professional habits that you'll need to maintain in order to keep improving and keep your skills sharp as you work in the field of medical interpreting.
So let's do this quiz. Here's the question. A code of ethics provides guidelines for, and now you want to choose. Does a code of ethics provide guidelines for the rate of pay for workers? Yes or no? Does a code of ethics provide guidelines for role boundaries of the worker vis-a-vis, which means relative to, the client? For a medical interpreter, the client is the patient and families, and to some extent, the healthcare team. Does a code of ethics provide guidelines for how a worker can achieve a higher level within the hierarchy of his trade? Or does a code of ethics provide guidelines for the behavior of the worker towards his family? So let's quickly look at this. Does our code of ethics have anything to say about the rate of pay? We'll take a look at that down the road, but I haven't heard Eliana say anything about that as she was discussing the healthcare codes of ethics. I did hear her say something that would pertain to the choice B, role boundaries of the worker, which in this case is the medical interpreter, relative to clients. So that sounds like it's pretty aligned with what we're going to be looking at today. There is a hierarchy within our trade. There are some more highly professional medical interpreters than others, but I didn't hear anything about that in the scope of ethics description either. And in terms of behavior of the worker towards his family, there's nothing in the scope of ethics that pertains to that. So we will choose B. A code of ethics provides guidelines for role boundaries of the worker vis-a-vis his clients. The Interpreter Code of Ethics, why did we fight so hard to create it? We did fight so hard to create it. We have here some true patient stories about things that have actually happened in the medical arena. I'm going to tell you these stories. A female patient said, "My interpreter told me that the other main interpreter in my language in town would gossip about me. So I should always have my appointments with her. I should always make my appointments around my interpreter's schedule. The fact that I had to manage my schedule around the interpreter's schedule slowed down my course of treatment so much that I lost my insurance before I could finish treatment. And now I cannot afford to go to the doctor." Here's another story. "My interpreter was with me when I had to terminate my pregnancy due to very severe abnormalities in the fetus. The interpreter kept telling me that God does not allow abortions. I am so depressed that I cannot take care of myself or my 2 children." Here's another story. "My interpreter took a picture of me and posted it on his Facebook page. I hope I can hear you gasping out there." Here's another story. "When I go to the heart doctor, my interpreter likes to talk to the doctor in English. He tells everyone that he went to medical school back in his country. The doctor hardly pays any attention to me as his patient, and the interpreter tells me not to ask so many questions, just to do what the doctor instructs me to do." These stories illustrate what the healthcare looks like from the patient's point of view. In each case, the patient is anguished by the fact that his experience with the healthcare setting has not led to his happiness. it has given him additional burdens. And in each case, the patient specifically indicates that it was the interpreter and the way that the interpreter performed his function and the way that the interpreter decided to relate to the patient and relate to the care team members that became a problem for the patient when he was trying to get care. So that, in a nutshell, is what we're going to be talking about during this ethics orientation. Is medical interpreters are there to make the patient's access to care equal. We are there to put the patient on an equal playing ground with English-speaking patients. We must be very careful not to add any burden to the patient's efforts to get care. So we want to bring up the possible situations where we might become a burden so that we can avoid becoming a burden. The elements of the Washington State DSHS Interpreter Code of Ethics are on this slide. I am going to read them, and then we will go over each element in turn. Accuracy, cultural sensitivity, courtesy, confidentiality, proficiency, compensation, non-discrimination, self-representation, impartiality, conflict of interest, professional demeanor, reporting obstacles to practice, professional development, scope of practice.
So let's take a look at accuracy. Accuracy or completeness. So we all know that you can't use the same number of words when you interpret, and that the word order is almost always going to be different, and that with specific language pairings, it's going to last longer in the other language than it takes to say it in English. But essentially, what is communicated at one end, the picture that is painted at one end, should look the same at the other end when you deliver it to the other party. So you are transmitting the fundamental meaning, which means it's really important to not leave anything out, and also to not add anything that wasn't there originally. Don't change anything. It's okay if it takes more words to create that same picture, but it should have the same content without skipping something and without adding something. And it's important when you do that to also transmit the tone. That's why we don't like those robotic computer voices. It makes a big difference when somebody says, "How are you doing?" and the person says, "I'm all right," versus, "I'm all right." And it's important for us to include that ingredient of tone in that picture we paint in this second language.
So, Ileana, I have a question about that. When I hear someone speaking in Cantonese, it sounds as though the person is ending every sentence with an upward inflection. So I have a really hard time figuring out what that person's emotional content or tone is, because I don't have the same cues as I get from an English speaker. I'm an English speaker. I can follow intonation and tone in English and get meaning from it. So if I had a medical interpreter, let's say I were in China, and the doctors and nurses were speaking to me in Chinese, in Cantonese in this case, my interpreter, are you telling me the interpreter would be telling me the tone as well? Because I wouldn't be able to pick that up on my own since I don't speak in the Cantonese way.
Well, your interpreter would be transmitting the tone of whatever tone that speaker he's interpreting for is using. So I don't think you can necessarily assign a tone to a language or even a cultural group, but it's a very individual thing. I happen to be Brazilian, but not all Brazilians like to go to the beach and dance and play soccer, although it's hard to find the ones that don't. So it really has to be a determination that you make on a person-by-person basis and do the best you can to relay the way they are presenting themselves to you who speaks their language and understands the culture they're coming from, for you to give that same impression over to the other side. Now, sometimes there are misunderstandings. I'm half Italian, so often if people came to eat at my house, they would say after dinner, "Why was everyone so upset? Why was everyone yelling?" And no one was really fighting in Italian, but that's a cultural thing. So sometimes, and we'll get to that later, sometimes that clarification or that cultural brokering needs to take place so that the provider gets a good sense. No, they weren't angry, they were just intense or very sincerely trying to make their point with a lot of enthusiasm, which might be perceived as anger in a quieter Pacific Northwest culture. So the interpreter is there to help realign the compass and make sure people are really getting what the intent was. And again, body language as well as tone, as well as many things that are specific to the culture that you yourself either know a lot about or are from. These are all things you can perceive and understand much more quickly than the provider who doesn't speak that language and has never been to that country. And it's also important, if there's ever any doubt, you clarify. You clarify your own understanding of statements from all parties. And sometimes there's time pressure, or, always there's time pressure. And people say things quickly. And you want to make sure you got that medicine name correct, and you got the dosage correct, and the number of times a day, and you may have to ask for repetition or clarification. But these are standards of practice that we'll get to once we finish examining ethics. So overall, it's just to notice and be aware of the integrity of the entire message as a whole. If you don't understand it, perhaps there was some ambiguity or somebody misspoke, you ask for clarification and you make sure you understand what you're attempting to interpret before you try to convert it into that second language.
So, Ileana, are you saying that it's more important for me as an interpreter to be accurate than it is for me to be really fast and look like I know what I'm doing?
I would say so, particularly if you imagine somebody you care about in the chair of that patient. Fast and slick is not what I want for my grandmother. Accurate and helpful is what I want for my grandmother. So here we come to problem solving when we're faced with dilemmas in accuracy. As I mentioned before, asking for clarification is always the right thing to do. So it's important to let the provider or the DSHS representative, or on the other side, the patient or client, know if you did not understand something, if you did not understand what they said. Sometimes people speak very softly. Sometimes I've interpreted for people who forgot to put their teeth in that day, and it is a challenge, and you may have to ask for things to be repeated. But never assume, oh, I think this is what they said. Always check and verify it. Ask them to explain it. For example, for Spanish, it's spoken in many countries around the world. There's a lot of regional variation for something as simple as the word for peanuts. And you want to verify and ask for an example if you've not heard that word before, so that you can render the correct interpretation. Never, ever guess. And for the same reason, you want to write down numbers, dosages, names of medications, so that you can repeat them correctly.
So should I, put up my hand and say, oh, you're just starting to talk about numbers now. Let me rummage through my bag and see if I have a pen. Oh, can I borrow your pen? Is that what I should be doing?
There's a certain toolkit that I would say is important for all interpreters to carry with them. That's a small pad, more than one pen, because they run out. Tic Tacs or throat lozenges, whatever your favorite thing is, along with a small bottle of water, and have that in a small bag or fanny pack so that you're not putting stuff down in all of these contaminated environments and bringing it home with you. We need to keep our voices moving, we need to hydrate, and we need to be able to blow our nose when we have to blow our nose, but most importantly, we need to be able to take notes as needed and also remember to hand them to the front desk person to put in the shredder bin, and don't carry them out of the facility with you, whatever notes you've taken. So we mentioned before about conveying tone and emotion, and that includes when people are upset. If they say they hate this hospital, I'm sick of this doctor, if they use bad language. Because remember, that happens to people that speak English too. And when they're upset, they're sick of being in the hospital, and they're telling the doctor, I'm sick of looking at your face, I want to get out of here, the H out of here. The doctor hears it and understands it and deals with it from there on in. He knows the patient is upset. There needs to be some de-escalation and reassurance that needs to take place. So it's not within our responsibility to edit or censor anything that is said, even if you disagree with it, even if you think, oh, I'm a nice religious lady and I don't ever use bad language. If the patient said it, you need to be able to know what the equivalents are so that you can say it in English for the provider. The provider needs to know the patient is that upset, and the provider needs to take steps to manage and de-escalate the situation. And the same way we are open and transparent about interpreting negative emotion or bad language, we also have to be open and transparent about correcting any mistakes. As soon as we realize it, openly. And often mistakes aren't that big. It doesn't matter, big or small. As soon as you realize it, put your hand up, make the letter T with your hands, whatever gesture that you use to interrupt, and let them know. The interpreter would like to correct. I just realized I used the word rifle instead of shotgun when I was interpreting. It was the first gun word that flew into my head. But upon reflection, I realized the better interpretation would have been shotgun. What makes a difference? Shotgun is a much bigger wound entry and exit than a rifle, although the story as it was told with the incorrect word, rifle, everyone understood. But as you go on, sometimes you realize, oh, I have a better word than the one I used. Let people know. Everyone always appreciates the correction and respects you for making the correction as opposed to being concerned with looking slick and quick. We all know that all of us make mistakes on a daily basis, and we're all trying our best. And being transparent about making your own mistake only adds to the trust that people have in you as the interpreter because they know you're honest. You're going to be transparent. If there's ever a time when you go off track, you will immediately circle back and make sure that we're right back on track. And that's a very good bond of trust to build with the people with whom you provide service, be it providers or patients and their families. Melinda, you've got some more anecdotal stories for us.
Yeah, I have a story that I would like to share because one of our interpreter staff at this hospital came to debrief with me, and she told the story of having just been to see a male patient who was very angry about how his treatment was going, the fact that there were some things happening in the development of his illness that were not looking very good, and he had expected to just kind of sail through, and these things were really quite bothersome to him. And as he was talking to the doctor about what was going to come next in his treatment, he made very rude and aggressive comments to the doctor. And the interpreter standing there is a very dignified and charming woman who would never say anything rude to anyone in her entire life. I'm sure she never even yelled at her kids. But the important thing for this interpreter was that even though she didn't know how to say the rude words in English because she doesn't swear in English herself, she picked up on the fact that the patient was very angry and was trying to tell the doctor that he was not happy with the situation and that he was using very rude words, which were pretty much outside this gentleman's normal way of speaking. She realized that this was all very important information for the doctor to have. So instead of trying to find the exact same words in English, what she did was use her interpreter voice. She said the interpreter would like the doctor to know that the patient has just used some very angry and rude words about you and about the hospital, and then I will continue to interpret from there. And she continued to interpret in the first person like we normally do. She felt that she had done a good job, and I agree, because the doctor clearly got the message that the patient was upset and was so upset that he had outstepped his usual personality and had used rude words, which normally he would not have done, and that the doctor had to take that very seriously and meet the man where that man was at, to talk to him where he was in his emotional response at that point. So she was accurate.
So let's go over the quiz for accuracy. Here's the scenario. The provider uses a term that you do not understand while explaining to a patient what might go wrong during treatment. So you, A, leave out that sentence. The patient already has enough to worry about. B, say to the patient, I did not understand part of what the doctor said about risks of treatment. Sorry. C, say to both the doctor and the patient in your interpreter voice. The interpreter asked the doctor to break down the term X for me so that I may interpret. I do not know or I am not familiar with the term X, Y, Z. Or D, remember the last time you interpreted for a patient having this treatment and repeat what the doctor said that time. So let's look at these one by one. Leaving out an entire sentence is not congruent with being accurate. Yes, sometimes the patient has a great deal to worry about. But again, it's not our job to censor any part of the communication or decide on anyone else's behalf whether they should receive or not receive certain parts of the communication. Our job is to, as completely as possible, carry that message that the provider painted, that picture, and have the patient see the same picture when we convert it into their language. So saying to the patient in B, I did not understand part of what the doctor said about risks of treatment, is a great way to then pause and turn around and verify what that would be. But not doing that, by only doing half, you fail. You don't just say, I didn't understand that, sorry, you're on your own. So the complete version would be to say to the patient, I'm sorry, I need to check with the doctor. I didn't understand one of the words that he used, and then turn around to the doctor and say in your interpreter voice, the interpreter asks the doctor to explain what X means so that I can interpret it for the patient. I'm not familiar with X. And then D, if we were all shoes, maybe a treatment for shoe leather would apply the same to all shoes, but we're not shoes, we're people. So someone having the same treatment might have an entirely different reason for having the same treatment. So telling this new patient what the doctor said last time to a different patient might have nothing to do with what's going on with this patient. So we can throw that answer out. So the correct answer is C.
Now we're going to talk about a very, very fun topic. It's cultural sensitivity and respect. It's a really fun topic because each one of us has his own cultural landscape. Each one of us has things that are important to us. I have things that are important to me, my deeply held values. I have goals. I have needs. I have preferences. And you do too, Eliana, right?
Absolutely.
Okay, so we're going to assume that everyone listening to this orientation has a cultural landscape, and every patient and every doctor and every nurse and every social worker and every DSHS worker and every DSHS client has his or her own cultural landscape. What we need to do to provide good service is to make sure that we are not trampling on anyone's cultural landscape. Number one, we want to avoid insulting anyone because then they can't get good care. They're too worried about us trampling on what they think is important. But also, we want to be alert to misunderstandings between our patients, clients, and the state health workers, other health workers, DSHS workers who are trying to provide services to clients because they might misunderstand the meaning or the intent of what is being said by the other party. We want to be alert to that, and we want to just, using our interpreter voice, interject a suggestion that the worker check with the patient or check with the client to see what the client means by what he is saying. What value does that have to him? And we are not speaking for the patient. We are not speaking for the client. We are not explaining the patient to the care team. We are not explaining the client to the DSHS worker. What we are doing is giving the floor to the client or the patient and showing with our example that it is important to understand the meaning of what the patient or client is saying. We'll tell you a true story. Unfortunately, in this story, a lot of us made some pretty serious mistakes, and we learned from that, so we're passing on the story. And it has to do with cultural competence because a lot of people on the healthcare team made a mistake of assuming that a particular patient had certain cultural values. And we got it wrong. So here's the story. One of our patients was diagnosed with cancer, but she was not told that she had cancer. The family requested directly to the doctor team that the patient not be told that she had cancer. The family was quite brutal with the interpreters and insisted that the interpreters not say anything using the word cancer. Even though this lady walked into the cancer clinic a couple times a week and it had cancer written over the door, this lady was from a country where the alphabet system is very different, and she could not read the fact that it said cancer. So she really did not know that she had cancer. She got sicker and sicker and was an inpatient, and when she got very, very ill and the care team was trying to figure out how to approach the patient to ask her for her end-of-life wishes, a new doctor who just joined the team walked in and just blurted out, "So how are you doing now that you know that you have terminal cancer, end-of-life cancer?" And the patient was very surprised to hear that she had cancer at all, let alone end-of-life cancer. The patient was shocked, and she let her family know, and she let her doctors know that they had made an assumption about her cultural landscape which was incorrect, and that she did not have the time that she wanted to put her affairs in order. And she died a couple of weeks after that. So from now on, this hospital makes sure, with an interpreter present, to ask the patient what his or her needs are for information. What do you want to know from us? If you have tests, do you want us to tell you the results? And then we honor that. So the interpreter, of course, will be following the lead of the medical team. And if we had this lady there again, at this point, the care team would have asked her, "How would you like to receive information about your tests? Do you want to know the exact results?" And this lady would have said, "Yes, I want to know the exact results." So at future visits, the doctors would have said, "Mrs. So-and-so, this is the results of your tests. You have cancer. It is doing this, that, and the other thing." And the interpreter would have said, "Mrs. So-and-so, the results of your tests show that you have cancer, and the cancer is doing so-and-so." And all of that would have been right because that was what the patient wanted. So in this case, being culturally appropriate is doing what is important to the patient. We are meeting the patient in the patient's landscape after we have asked her what her landscape looks like. So that's where we as the interpreter follow the lead of that care team, and we fly wingtip to wingtip with the doctors and nurses as they then honor the patient's cultural landscape. So in this stew of all of these people interacting, we have our own cultural identity. Where do I come from? What have I gone through? What have I decided is important to me? Where am I in my own lifespan? Am I a new parent? Am I the parent of a teenager? Am I nearing my own death? Where am I in my lifespan? What have I experienced? What do I think is important? And then I look at my patients. For every single patient, that patient has some deep values and some desired outcomes for his healthcare journey and some fears of what he might encounter in the healthcare setting. Every patient has healthcare beliefs. What works? What doesn't work? How were his illnesses caused? What might make them better? Every patient has his own way of interacting with the healthcare system, and he has different comfort requirements. Every single person on the care staff has his own cultural landscape. They get up in the morning and they think, "Wow, why am I going to work today? What is the most important thing for me to do today? What is my higher calling?" American medical culture has certain things that it values, and we institutionalize those values. For example, we highly value directness, which is putting the information out there, making sure the patient has the information in a clear, almost brutal way sometimes. We highly value speed. Come in, I'll tell you something, you tell me back. You go home. Quickly. Make decisions quickly. Hi, patient, you have this going on. You need to make a decision about it. Can you make a decision for me right now, please? I have another patient in 10 minutes. Please make that decision now so that we have 7 minutes to discuss it. And we also value commitment to a course of treatment. You may have noticed that when a patient is being seen and a treatment plan is given to the patient, the care team expects the patient to actually carry it out. That's part of the expectation. If the patient doesn't carry it out, often we don't ask the patient, so did you have trouble carrying it out? Were you not committed to carrying it out? What was problematic for you? Were you just not getting around to it? And instead, we punish the patient by calling him non-compliant. That's part of our American bio-culture. And if a patient is involved in research, there is another subset of culture which has its own rules. And those rules are, we're doing things, we're offering the patient different courses of action, which may not actually help this particular patient at all. Because in many research situations, the patient doesn't know if he's in the group that is doing the new treatment modality or if he's just doing a placebo, which is not going to help him. So in research culture, it's kind of different because you don't really know if the patient is getting treatment or not. So that's confusing for everybody. As the interpreter, we have to fly through this canyon with all of these different cultural landscapes going on at once. And what is our job? Well, our job is to be accurate and complete and respectful and alert to misunderstandings. So our major job is to try to sense if there is miscommunication or misunderstanding because people have very, very different cultural landscapes, and to raise the suggestion in our interpreter voice that the care team person might wish to ask the patient or the client to explain what is important to him about what he just said, or to clarify that something is important or is not important. Or the interpreter might suggest to the patient who says something that really indicates that something is important to him. The interpreter suggests to the patient stating that clearly to the provider, and we say that transparently in both directions, because we kind of heard it, but we want to make sure that we heard a message of cultural emphasis clearly, so we can ask for clarification, ask the patient to state what he said clearly when we think there is a cultural statement that the patient is making, so that he can be heard through us as the interpreter. So here's a quiz. You may have all heard this story already. This is a true story. There was a family with a child who took the child to the emergency department because the child had bronchitis. And when the child was examined, there were bruises and scratches on the child's back that looked pretty angry. And the care team was concerned. I mean, they were going to take care of the bronchitis, but they were pointing at these welts on the child's back and looking at each other with raised eyebrows, which the interpreter noticed. And the interpreter had been around quite a lot in the ER, and he knew that child abuse would probably be a concern. And sure enough, he heard the care team muttering to each other, you know, saying, boy, maybe we should call CPS. The interpreter himself did not know what had caused the welts on the child's back. The interpreter was not making a diagnosis, but the interpreter knew that there was a cultural healthcare practice in Southeast Asia. Cupping and coining are two different pieces of this practice, which are often practiced on someone with a bad cold or a bronchitis, and which leave marks on the back. And instead of saying, oh, this is what's going on, the interpreter suggested transparently, telling the providers at the same time, the interpreter suggests that you mention to the provider what has caused these welts on the child's back. And the family then was able to make a statement to the provider team explaining what practices they had used and why they used it, trying to cure their child in using their home remedy of cupping and coining. So I've kind of told you the answer, but A, B, and C are some of the challenges that come up for us, so let's go over those. The interpreter, unfortunately, sometimes makes this choice. The interpreter gets the doctor in the corner and says, "These are ignorant peasants, and they employ superstitious home remedies. These bruises are evidence that this family is going to be hard to convince to use modern antibiotics." And I have seen this happen, unfortunately, where the interpreter, who is educated and comes from a city, is very ashamed of members of his or her language group that come from perhaps a rural area or perhaps are less educated or might just come from a different part of the country. And so the interpreter talks down about the patients. We want to make sure that we never do this kind of culturally insensitive behavior. We always start from the position that the patient is of value, the family is of value, what they believe is of value, and that we're going to respect that and represent them respectfully to the care team. Interpreters sometimes also do another thing which is not good, which is letter C. The interpreter sometimes gives a lecture to the care team about how important and valid home medical remedies are, in a way that's advocating for the culture of the home country and telling the care team that they need to respect the patient's home culture. But the interpreter is talking about the patient. He's talking about the family. He doesn't have any right to do that. The family can represent itself. So we never want to speak for the patient. That is why C is absolutely wrong. We do not want to advocate. We just want to support the patient in speaking for himself.
Okay, that was a big piece, Linda, and it's a tricky one to manage, but transparency is the key. Both sides need to know what's going on as it's happening, and your benefit of knowledge of that culture and its practices is always of great help to the providers and keeps things from falling through the cracks or going the wrong way for your patients and their families. Our next big piece has to do with confidentiality. Now, this is a piece that most everybody understands up front why it's important to keep intimate medical, physical history details about anyone confidential. And what I want to say is that hardly anyone intentionally violates confidentiality. Nobody takes out an ad in the paper saying, "Guess what? I interpreted for so-and-so yesterday, and they have a sexually transmitted disease." Nobody stands in their church or in the public square shouting or repeating details that they were witness to or interpreted for yesterday while they were at work. That's not how confidentiality gets violated. It gets violated by accident. It gets violated when you see a patient that was very sick unexpectedly in public and you say, "Oh, it makes me so happy to see you doing so well." Well, you just breached confidentiality, because anyone who was listening can put two and two together and realize, oh, if they're doing well, they must have been sick before. You kind of let some information sneak out that shouldn't have gotten out. It's very tricky when you meet patients in public because they're almost always very happy to see you. You've helped them get the help they need. You've helped them understand how to take their meds and they're feeling better. You helped interpret for them when they were frightened and they got through that frightening experience and now they're back with their family. So they want to introduce you to everybody. They want to invite you to christenings and weddings. It's very hard to maintain the warmth that is expected from many of our cultures while saying very non-committal things like, "Hi, how are you? Nice to see you," and stray not from these very lame recognition of knowing this person, but it's the safest thing to do. So we want you to seriously consider all the ways that confidentiality could be violated by accident so that you can guard against doing so yourself. Often, these mistakes come from a place of compassion or wanting to be helpful, and most slip-ups tend to happen in this arena. So what is it that needs to be maintained confidential? What is PHI, Protected Health Information? That's what we need to protect. In certain cultures, in certain communities, depending on the kind of information that if it were to get out by accident, this patient or this client or their family could be put at great risk for violence and harm. People have been killed or ostracized by certain types of personal health information that has been revealed to their community or to their family. Any kind of leakage of this kind of private information, especially if it's traced to the interpreter, only builds fear and distrust of interpreters. We're trying to teach people to rely on trained, educated, skilled, certified, authorized healthcare interpreters rather than bringing their coworker or their neighbor that speaks English a little bit better than they do, or, God forbid, one of their children under the age of 18 who speaks great English to interpret for them. We want them to rely on professional interpreters, and for that reason, it is so very important that professional interpreters should be trusted to never drop the confidentiality ball. So, who is it okay to share personal protected healthcare information with? The treatment team, if it's an inpatient, the charge nurse or the providers that come into the room. If something happens that you want to get more information about, you can go back to your supervisor, your manager, to say, this happened today with patient X, Y, or Z. This is how I handled it. Could I have done something different for it to go better? This is how we learn from sharing with people that work in the same area as we do. But it has to be done in a safe place. It can't be done in an elevator car full of people. It can't be done in the hospital cafeteria. It has to be done in a room where you can close the door and know that you're not going to be overheard. So those open-sided office cubicles, that's not a good place to go and discuss patient-specific questions that you may have. But there are always people at the facility where you work where it's safe to discuss what you need to discuss.
So I have a question, Eliana. I hear the term de-identified information. I like this term because it immediately tells me that I can say something about the patient's situation, but I don't put his name, I don't attach his name to it, I don't attach his medical record number to it. But so if I need to debrief about my technique or how I handled something, I can say, Eliana, I need to debrief with you. I just participated in the care of a patient. I am not going to give you, Eliana, this patient's name or any other identifiers. However, this was the situation. Do you think I did the right thing when I handled it this way? So we're talking about what happened professionally. You can help me, give me the benefit of your experience, but I am not sharing the actual identity of that patient with you. So I love that term, de-identify the information, because it gives us a way to separate, never talk about what happened with, you can talk about what happened if it's for a professional reason, like those things that you just talked about. You need to learn from your experience, or you need to go back to that patient tomorrow and you need more information to be more efficient. But in each case, we don't need to bring up the patient's name.
No, you don't need to bring up the patient's name, the patient's date of birth, even the clinic or the disease or treatment that they're undergoing, because all of these discussions hardly ever have to do with the medical procedure or treatment. It has to do with interactions between interpreter, patient, or family, or provider. Everybody has a bad day. Sometimes there's a cranky person in the room. Sometimes you just need to verify, did I handle that correctly? Did I de-escalate that properly? Did that person that was upset, did I give them the best information or only the above average information? Could I have done better? This is how we all grow. And one of these days, that cranky person or that underperforming person might be you. So let's see, where were we? So we share the personal protected health information only in those places that are safe. We de-identify that protected health information so that we can discuss the skill set needed or the situation and how it could have been handled better so that we can learn from that situation. You know, truthfully, I do learn a lot more from my mistakes than I learn from my successes. So everyone makes mistakes, and the way you learn from them is being willing to do an autopsy on them and figure out what could have been done differently. So there are circumstances where you will be asked for protected health information by people who are empowered to ask for it, whether it's from the healthcare center or from DSHS. But gossip is never the correct way to share protected health information. This is usually done in an appointment or a face-to-face, or there's an email, whether it's from the social worker or from one of the providers, or a referral to some sort of other therapy or treatment. These people, you know, obviously are part of the healthcare team. But talking out of the side of your mouth, saying, oh no, here comes that cranky patient who always throws a tantrum, or there's no need to share personality quirks outside of the encounter. You can talk about it with the provider. If the provider wants to know, this patient is always so angry every time they come here, have you heard anything that might help me figure out how to better connect with this patient? But it's never lunchtime conversation with your coworkers. It's never, boy, wait until you hear what happened with me at work today kind of conversation. It's always within the boundaries of either your own debriefing for professional development or debriefing within the healthcare team for patient care. So this applies, that quote-unquote gossip, also applies in knowing the rules for what kind of info can be left on a message machine. Some of us are still old enough to have a recording device. Most of us have it go to voicemail on our phones. Some things are okay to leave on voicemail, other things are not. You may only normally be able to say, we've tried to reach you, here's our contact number and the facility you're calling from. But then again, if the facility you're calling from is HIV clinic, you might just say, this is Harborview Medical Center. Can you please call us back at number XYZ? Personal and electronic notes, texts, If your agency sends you information about where and when to meet a particular patient, these things need to be deleted. Notes that you write during encounters, written schedules that may detail some patient information, like the name of the clinic, the first and last name of the patient, or their medical record number, that cannot be folded up and go in your purse and go home with you at the end of the day. All of these things benefit from knowing where the shredder is in the clinic or inpatient unit where you are. You don't know, you ask. You don't go home with it. You don't risk having your purse stolen containing this kind of PHI, protected health information. If you take notes on a laptop, it has to be de-identified. Lots of people take notes for words that they may come across or new procedures or new drug names that they're going to go home and research so they can better their skills. That better be on the other half of your notebook where you've been taking notes for the encounters for the mom with all her kids' names and their birth weights and stature measurements. That does not leave the clinic, does not leave the hospital. Keeps you safe. If they could make those little whiteboards really small with really clear markers, that's what I would recommend, because as soon as you're done taking notes, you can just wipe it clean, and then there's nothing that you need to destroy. But until we transition off paper and pen, that paper needs to be shredded and not travel outside that medical environment with you.
And your phone, if you have any information on it, needs to have a password that only you know, so that if you leave it in the bathroom and someone else picks it up, there is your daily schedule for who your patients are at the next 3 hospitals is not there for them to see, because they can't get past your password.
And it's perfectly all right to ask a front desk person or somebody who works in the facility if you have not found the shredder bin, generally a locked trash bin with a slot for PHI to be dropped into that gets carted off and shredded. That's fine. They know where it is, and you just say, this paperwork contains PHI. Would you please put it in the shredder bin for me if you can't find it on your own? So that answers that question of, what do I do if I can't find the shredder bin? Just ask someone to dispose of it properly for you.
Unfortunately, we need to regain public trust. We have heard stories from patients, and we have heard stories from interpreters in interpreter classes, in interpreter trainings, who recount stories from patients that have told them that those patients have heard stories about other interpreters somewhere in the community completely betraying their trust and that bad things happened. So as a group of professional health workers, we as medical interpreters have to work pretty hard to regain trust. Some of the things that have been told about are somebody's pregnant, somebody's had an abortion, somebody's practicing birth control, somebody has a mental health condition, somebody's had a test for cancer or is being treated for cancer, HIV. They took their kids to the autism clinic. And these things may not be very significant in American middle-class culture, but even for many communities in the United States, patients born here or clients born here in the United States, there are certain kinds of healthcare concerns and mental health concerns and social needs that nobody wants to be shared. So as Ileana said, we want to just be super careful about not letting anybody know what we know. Sometimes if we raise our eyebrows or we smile in a happy way, let me give you an example. Your patient has just gone back in the prenatal clinic and she has to wait back there because she's going to be taking a test. So you go back out in the waiting room, and her grandmother's out there. And you've been with this patient, and everything is going well with the pregnancy, and she's actually going to have 2 babies. And the grandmother says to you, the grandmother comes over to you, and she says, wow, I'm so glad that you're our interpreter again. It's so great because you're really great as an interpreter. We trust you a lot. And I've just been kind of wondering as the grandmother, I'm looking at her, she looks pretty big. I'm wondering if maybe she's going to have twins. And you have to really watch your face at this point, because it's so easy to smile and nod. It's really easy to smile and nod. You want to share that happiness with the grandmother. But you know what? The grandmother is not back there with the patient, and it's the patient's right to talk to the grandmother and to give her that news if she wants to. The patient might want to hold on to that news for a bit longer. She may be worried about it. She may not be ready to talk about it. She may be still in shock that she's going to have 2 babies. It's not up to us to give that away, even by smiling and nodding. Even if I don't say any words, I've given it away. I've betrayed my patient. So how do we avoid breaking confidentiality there? First of all, we keep control of our face. We distract the grandmother. We say, it's wonderful that the patient has you as a support person. I'm sure that's very important to her. She will be able to share with you any information that she wishes to share with you when she comes out. She'll probably be out in about an hour. Oh, by the way, do you think it's going to rain today? That's one of my favorites. So that's what I recommend.
Remember, even if the granddaughter was intending on sharing this information, it's really not fair for you to steal her thunder, so to speak, and acknowledge that this is taking place, even if you didn't actually say so with words. But that twinkle in your eye and that grin that you didn't catch before you wiped it off your face just let the secret out. And we really don't want to take away anyone's joy, just like we don't want to add to their burden. It's tricky sometimes, so practice your poker face. Or anyone who's been a parent, there are certain times when your kids have done something and they've misbehaved, but you can't start laughing because you will lose all control. So you have to keep that stern expression on your face when you tell them to go clean up or to help you clean up their baby brother that they just painted blue. And you can't lose your authority by allowing that smile to hit your face, and you can't lose your trust by allowing that smile to hit your face when you interpret for people, because they know, wow, I did my best to worm the truth out of her and she just didn't let it slip. So next time I need an interpreter, I'm going to trust her because I'm good and she didn't give me what I wanted.
There you go.
So we want to help you out with the tactful way that you need to back away and be ethical in these situations. We have some suggested scripts for you to use, and the scripts come in handy if you're not in the habit of turning away these requests as professionally as some of these suggestions do. They're very clean. They don't leave you fumbling. They leave you clear, transparent, and professional rather than bumbling, fumbling, and saying, oh, but I don't really, And that kind of assertiveness, as opposed to aggression or passivity, is what you need to stick to your guns. So, for example, here's a clear messaging script to avoid sharing any information with family, friends, and coworkers who are anxious to know what is going on. And this happens if it's a particularly popular coworker or a particularly popular provider that all of a sudden is an inpatient in the hospital where you work. People will be there interpreting for other patients in a critical care unit, and they'll recognize that person. But respecting confidentiality, we can't go back and say, oh, let's buy a get well card and circulate it amongst everybody to sign it and deliver it back, because we weren't directly informed by the family because of a close relationship of what's going on. We are not on the visitors list. We, by happenstance, because we were in the next curtained bed area over, came across this information. So others may also know that this particular provider or coworker is in that unit and may ask you if they know that you saw a patient in the same unit. And you have to find a nice way to turn it around. It's like, I know I like that provider too, but if you really want to know how they're doing, please ask the charge nurse directly, or if you know them well enough to know the family, please communicate directly. Don't put me in the middle in that difficult position of being privy to some information which we both know I'm not supposed to share. And it's just as important to report any observed breach of confidentiality. That includes finding patient notes or appointment schedules or interpreter schedules in the ladies' room, on the sink where I found them before, or in a knapsack that gets left behind when the person realizes what time it is and gets up and grabs their purse and goes running off to their next appointment. If they leave their knapsack behind, their notebook, the pad where they write their notes could have been contained inside, and it's really at the mercy of whoever finds that bag, which is why I recommend the fanny pack or any kind of belt with a pouch that you can put some money, your keys, your phone, but not have something that you can put down and forget. So it's important that you are able to assure each patient or client that you're committed to protecting their privacy as your interpreter. I do not mention or discuss anything about your care to anyone. Another one that I often use is everything that is said in the room stays in the room. I don't carry it anywhere else. And then you need a script also for when you walk into a room and you come face-to-face with someone that you don't know well, but that you bump into quite often on a regular basis. It could be your kids go to the same school. It could be you both sing in the same church choir. Your sons are in Cub Scouts together. There could be a lot of reasons why once a week at swim class or dance class, when you're dropping your kids off or picking them up, or some volunteer activity, or there's an endless list of places where you could regularly meet up with somebody that is not a close friend or within your intimate circle, but that you will be regularly seeing each other in the future. It's okay if you sense that person is uncomfortable to say, because we're both on the PTA together or because we're both on the school board together, would you feel more comfortable if they replace me with a different interpreter? You're going to sense that level of uncomfortableness, if that's a word, from someone. You know your culture. You know when somebody's fidgety or shut down, and that's a very kind-hearted thing to do if it is all possible within the scheduling for the people you work for. If you know you have that, we tend to rub shoulders on a regular basis, even though we don't know each other well, you can offer the patient that out.
And they'll tell you.
They will.
They'll say, oh, no, I feel fine. It's no problem. I think you're a great interpreter. I have no problem with your being my interpreter. That would be great. Please stay. Or thank you for offering to have yourself replaced. It would actually make me feel much more comfortable to have someone as my interpreter that I have no personal connections with.
And that's when you say it's important for you to feel comfortable and able to communicate with your provider, let me see about getting a substitution, or at least making the note from here on in to not assign me to your case.
Exactly. So we have a quiz here. And this time we'll do it like a quiz. So the interpreter returns to the surgery waiting room while the nurses clean up the patient after some post-surgical vomiting. Patients do that. They vomit after surgery. The mother-in-law of the patient is waiting in the waiting room and engages the interpreter in conversation. She begins with saying, "What a great interpreter she is." That's usually your clue that they're going to ask you for some information. The mother-in-law then asks the interpreter if the patient has shared with her, the interpreter, that the patient's unborn baby's dates do not match her date of marriage. The mother-in-law wants information from the interpreter about the patient's unborn baby. So there are some choices. The interpreter should, A, jump up and tell the mother-in-law that she should not gossip about her pregnant daughter-in-law. Or B, say that the information about the patient is not something that can be discussed by members of the care team, including by the interpreter. C, say that indeed there have been cases where babies have suspicious dates, but surely her daughter-in-law must be virtuous, ? Asking for more information from mother-in-law, making innuendo and raising the eyebrows. So which one would we do? As the interpreter, would we jump up and lecture the mother-in-law that she should not gossip? Probably won't go over very well. It's really what we want to say, but we're not going to say it. What we're going to do is say what all members of the healthcare team say. So if the mother-in-law approached the nurse or the receptionist, she should get the same answer, which is, information about the patient is not something that we can discuss as members of the care team. And we certainly do not want to engage the mother-in-law in further gossip about the patient. Proficiency. What does proficiency mean? Proficiency means, are you good at it? Can you do it well? Elements of proficiency that are required and expected of an interpreter by patients, clients, DSHS staff, the care team, purchasers of service such as the hospitals, regulatory agencies, and the community include the following points. Interpreters are expected to have linguistic proficiency in both languages. They're supposed to understand and be able to use medical and social service vocabulary in both languages. They are supposed to know the terminology related to science, math, biology, anatomy, physiology, human development, mental health. I could go on and on. Anything that is related to the practice where the interpreter is accepting assignments in both languages. Not just some knowledge of these terms, but must be proficient, must be good at it, have a high level of knowledge and skill in linguistic proficiency. The interpreter is expected to have excellent professional business management skills, dependability, trustworthiness, customer service, time management. The interpreter should be completely aware of what his contract involves. The interpreter must understand basic healthcare and social services operations, where to meet clients, what comes next, what to expect. If you encounter your patient or your client at one part of the process, you as the interpreter need to know what's probably going to come over the rest of that day, over the rest of the next few months. You need to be able to prepare so that you can be proficient in what terminology is going to be expected of you. where you might be asked to, to show up to meet the patient. You need to know check-in and check-out procedures. And interpreter mechanics. What does the interpreter do? When you walk into the room, what are you expected to do? All of the doctors, nurses, social workers, and patients expect the interpreter to know what to do. How do you interpret? And interpreter ethics. You're expected to be proficient in following your role boundaries, in managing your relationships, in knowing what is in scope and what is out of scope. Unfortunately, we have lots of stories of low or lacking proficiency. There was an interpreter who signed up with several agencies claiming to speak fluent Mandarin and Cantonese. He did not speak Cantonese. His grandmother had spoken Cantonese. He had learned a few words from her, but he was not able to actually speak at an educated level in Cantonese at all. He was given Cantonese assignments by his agency, and what he did to cover for himself would be that he would stand back, the patients' families would interpret, the interpreter would get paid, but he didn't have to do anything. This particular interpreter got away with this at least 4 different times in one clinic before he was turned in by the care staff, because the family never turned him in. Here's another story. There was a wonderful interpreter from a very rare language group who had a doctorate in English. But her pronunciation had never been corrected because she came here directly from her country, where she was taught by people from her country who had similar pronunciation as her own. And when she came here and worked as an interpreter in her language and in English, the English side, the care team, and the social service workers were not able to understand her English. So even though she understood the content herself, no one who listened to her could understand her. So she was not proficient in her pronunciation, and therefore she was not a competent medical interpreter or social interpreter. Here's another story. Unfortunately, again, a true story. There was a patient at end of life, huge crisis. All the family had gathered from a foreign country at great expense. There was a very solemn care conference going to happen. All the care team was there. The interpreter rushed in at the last minute, dressed as though she was going to a discotheque, high heels, flamboyant clothing, cup of hot coffee in her hand. She spilled it all over herself and other people, and she had never interpreted before. She had no idea what the terminology meant or the protocol or what was going on in the end-of-life situation. The last story is a very common story, and that is that even in the simplest pediatric appointments, terms are used which we'd never use at the dinner table. So unless interpreters actually study the terminology of the parts of medical practice or social service practice where they are accepting assignments, they are going to come face to face with phrases and expressions that simply do not mean anything to them. They will hear the words and will not know what to do with these words. Let me give you this example. The pediatrician was reporting to mom, who had brought in her 6-month-old baby, and the doctor said, your child's head circumference is at the 37th percentile for American children. The interpreter did not have any idea what that meant. Now, we know that what an interpreter does when he doesn't understand something is immediately ask the provider to explain what it is, and that's fine. However, this is such a common piece of what an interpreter needs to know in a pediatric appointment, that for an interpreter to accept pediatric assignments, we would assume that he has done advanced work to understand the basic terminology that is used in those appointments. That is the proficiency level that we would expect from a medical or social service interpreter.
So here's our quiz around proficiency. Here's the scenario. A brand new interpreter accepted an assignment from his agency to go to a large psychiatric hospital for an encounter with a patient residing on a locked ward. The interpreter began to realize that he was in way over his head when the staff on the locked ward told him that they wanted to brief him on safety concerns for his patient before they locked him into the room with the doctor. The interpreter at that point should have A, disclosed to the staff and to the doctor that he did not have any experience in mental health or on inpatient psych units and was uncomfortable interpreting in the environment. B, if the doctor decides to continue the appointment, work very closely with the doctor throughout the encounter to make sure that he understood the meaning in both directions. Or C, go home afterward and start studying very hard to bring his proficiency in psychiatric encounters up to speed. D, tell his agency to send him to less specialized appointments while he improves his knowledge bit by bit. Or E, all of the above. So this is a difficult one, and it's not easy to self-identify when you are lacking in skills, which is why so many people don't do it, which is why friends and family members never do it. They'll just skip over that word that they didn't understand in English and have no idea how to interpret and hope really hard that it doesn't come up again. That's not what we're training and preparing you for. When you're in over your head, one of the first things you should do is let people know that you're in over your head. So the correct answer is every single one of those choices. All of the above, E. That is what you need to do. Disclose that you're out of your depth. If there's nobody to replace you, you work very closely, baby steps, making sure that everything is very clear at both ends of the conversation. When you go home, you immediately look up what's a mini glossary for psychiatric terms, what's a mini glossary for commonly dispensed psychiatric medicines. Look for an interpreting and mental health training that Notice may be offering sometime soon locally, and then let your agency know that this is what happened. I felt out of my depth. I'm going to pursue more training, but until then, you shouldn't schedule me for mental health appointments, particularly in a lockdown unit, as opposed to, say, an outpatient mental health appointment.
Let's talk about financial gain. The interpreter is supposed to accept what is offered to him under his contract as the full payment. So, for example, if an interpreter accepts a job directly from a clinic and the clinic pays him, he is supposed to accept that. If he's being paid by Labor and Industries, he accepts what Labor and Industries pays. If he works through an agency, he has a contract with that agency to receive so much money per hour, for example, and so on. The interpreter must not ask for or accept or hint at any additional reimbursement above what has already been agreed to before he accepts the assignment. Many patients and families want to give interpreters gifts, and they want to give interpreters gifts for different reasons. Sometimes because they're grateful, sometimes because in the country that they came from, a person gives gifts and bribes to everyone who provides him with service so that next time that person will again provide him with service. Kind of like a black market. It's expected. Maybe the family or patient didn't really think you did an awesome job, but they're still going to offer you a gift. You are going to be offered gifts, money, offers of entertainment. Come to the wedding, come to the supper. We'll buy you tickets to go to the sports game. You might look down and find that somebody has tucked money into your pocket or into your briefcase. If that happens, return it. And let somebody know that you returned it. Return it to the agency or return it to the place where you saw the client. It could be a DSHS office, it could be a clinic or a hospital. Return it, write down all of the specifics, and walk away. Do not develop a financial conflict of interest. Very often, the interpreter is part of a larger community of people that the patients belong to as well. And the patients may have financial needs. They may be looking for life insurance or to buy a car, or they want to send their child to a local community school. We all have commercial and financial interests in our private lives, and there are many opportunities for patients' lives and interpreters' lives to overlap. But as healthcare workers, we are not allowed to act on those. And we have, as healthcare workers, information about patients. For example, we might know that our patient is 85 years old because we're there at the visit where the provider says, "So how old are you?" And we hear the patient say 85. So we know that that patient is part of an age group who might have certain financial needs. But we must not act on that. We must not say, oh, who have I seen in the last 2 weeks who's over 70 years old who might need certain services? I think I'll have my cousin who's working in this particular business contact these folks and see if he can offer them his services. I bet they would really need those services. So the point isn't, is the service good for the patient or not? The point is, there should be no business connection whatsoever in any way, no information, no service, no exchange of money in any way between an interpreter and any part of the families or patients that are served or clients. It is not okay for an interpreter to let patients or clients know that he or she also does translation, because a lot of our community members have documents from back home that need to be translated. And it's a pretty lucrative job. We are not allowed to say that. That is a separate business arrangement, and we are not allowed to solicit any kind of business, including translation.
And just to be clear, solicitation doesn't just mean asking for work or telling them, hey, by the way, I do translations on the side, so if you have anything, send it to me. It could be something as simple as the patient asking for your card and you give them your translation services card rather than your interpreter card, or something that just walks the line a little too close. A lot of interpreters do translation, which is why I mention it. On the other hand, this does not bar you from having a website that says, looking for translations from English to this language and from this language back to English, I do them, etc. If the patient finds that on their own, it's okay. It's not okay for you to promote or to say, here's a bunch of my translation services business cards. Would you take them back to your community center or your house of worship or your neighborhood if they live in an apartment housing, something that would have it exposed to your target audience. You don't want to take advantage of your patient. You don't want to use them for your own financial gain or to leverage your media or advertising. I can put it that way.
And we need to remember that in any business arrangement, there are two parties. And if anything goes wrong with that business arrangement, then the two parties are not going to be happy with each other anymore. And if one of those two parties is an interpreter, think about that. Because now this patient or family member who had a bad business arrangement or outcome with the interpreter is not only going to be mad at all interpreters, but the patient may not want to ever go back to that clinic or to that service center because they know that that interpreter might be there. And so it actually prevents legal access. We are supposed to help provide legal access, equal access to our patients. When we have financial connections with them, we're actually making it possibly happen that they would never come back for services because they've had a bad relationship with us for business reasons.
And they don't even want to run into you by accident.
They don't even want to run into you by accident. Exactly. So to be ethical around financial gain, remind patients that they have the right to have a free interpreter under the law in this country. Remind patients that your services are being properly compensated. The way I say it is, thank you very much. I have a very good arrangement with this hospital. I'm very happy with the way I'm paid, and it is my pleasure to serve you as your interpreter today.
Non-discrimination, very much like confidentiality, again, is one of those areas that it is easy to transgress even though you think you're doing the right thing. So for this reason, I ask you to try to consider scenarios where it would be challenging for you to practice the profession of healthcare interpreting in a non-discriminatory way. All of us have our own cultural baggage, our own upbringing from our own families, our own religious and traditions that accompany our countries of origin, and all of us struggle with juggling and making things fit with life here in these United States. But for all of that internal personal struggle or belief system, none of that can show on your face, and none of that can show in the way in which you do your job. And that can be very tricky for some people, for a lot of people, not for all, but for most of us. So what are the two main points? The interpreter must not treat a patient or client differently from any other due to their likes or dislikes about the individual, their beliefs, or their community. So we can go to the obvious and say you can't discriminate against somebody because they are of a different race, and traditionally your family doesn't like people of that race. Or you can't discriminate against people because of their gender identification, or a homosexual couple because your religion disapproves of homosexuality. Let's turn it on its head and look at a situation where any of us would find it challenging to be non-discriminatory. What if you were the interpreter in the trauma bay in the emergency department on an evening when there's a multiple car crash with many victims? One car contained a mother, father, and several children that was heavily impacted, lots of severe injury. You're interpreting, And lo and behold, when you get done with interpreting for those injured children and speaking to the parents and calming them down, you get called into the next trauma bay. And there is the drunk driver that also needs an interpreter. It's really easy to identify with the family of victims and not feel as much compassion for the drunk driver that knowingly drank and then got behind the wheel. But I still have to do my best to interpret as accurately and completely without omitting, without adding, and painting that same picture at the other side in English that my patient, in my case, who would be speaking Portuguese, paints it in Portuguese. Now, I have to carry those messages back and forth, whether the person I'm interpreting for is the person that just beat the woman in the next trauma bay, the person who sexually assaulted the child that I may have interpreted for the week before and is now in the emergency room because family members caught up with him and beat him. There are many things that you come across that you know, quote unquote, who the bad guy is. But we interpret every day for people that we have no idea if they steal, if they beat their children, if they lie on a regular basis, if they cheated the state out of money. We have no idea. We just have to do our best for everybody. That's the way that keeps us ethically clean, ethically right, and above board.
And that's what healthcare is, right? Because the Code of Ethics for nurses, the Code of Ethics for doctors, for pharmacists, for therapists of all kinds, all include this same message, which is if you choose to be a healthcare worker or a social service worker, you have chosen to serve the public. You have not decided, well, if these folks are of a high enough caliber in my little notebook, then I'll take care of them. Otherwise, I won't take care of them. So as medical interpreters, we're just like that nurse and doctor. We will take care of the patient. We will practice within our scope of practice. We will do so proficiently. We will do so respecting them as the patient to have the right to have good service. And we will go forward with that and go home with a very clean conscience that we took care of our patient or our client.
Absolutely. So for this reason, for all of these points that we are reviewing, my challenge to all of you listening to this webinar is to think of how could this play out in a way that it would be difficult for me. Try to turn it upside down like I did with the interpret for the family that was in the car accident, and now you have to interpret for the drunk driver that hit them. Would it be harder? Probably. Could I still do it is the question that you have to ask yourself. Yes, I can do that. I am sticking to my code as my guidance system and not to what I think about this particular individual. Because we interpret for people who are in prison, and like I said, we interpret for people that, unbeknownst to us, do lots of bad things. That can't be part of our concern. That can't be on our radar.
So we do have some stories, unfortunately. I've known several interpreters who have refused to see patients because the patients had tuberculosis. I have listened to interpreters discuss with each other whether they wanted to see patients with certain other kinds of infectious diseases. I have known an interpreter who outright refused to accept an assignment to attend to a client who was transgender because it made her feel uncomfortable. The Seattle AIDS Council specifically contacted me to say that they were troubled because they were having a tough time finding interpreters in several common language groups to interpret for their HIV-positive patients. And in many cases, I have seen interpreters refuse to accept assignments to interpret for clients from a different tribe. I think in the old days, we used to think of ourselves as language workers, language people. But what's very, very important is to know that the medical interpreter is part of the healthcare team and the social services interpreter is part of the social service team. We are not just language workers in a vacuum. We are part of an ethical service providing team, and we see all clients as they come. We do not turn down clients or patients. Unfortunately, our body language can do a lot of harm to our patients. We may think that just by not saying words that are bad or harmful, that we are within the boundaries of the guidelines for our practice, but we are not correct in that. On my face, I can have a poker face, which is good. That's what Eliana was talking about before. I need to practice my poker face because sometimes my face shows my disapproval of people. And a patient or a social service client does not need to have the additional burden of the interpreter scowling at him or making a sarcastic face or using body language like an expressive shrug as though what this person is saying is of no account or is not believable. We all have very strong opinions, but we need to keep our opinions to ourselves, and if we want to be an activist, we can go outside of our healthcare practice and we can be an activist on our own time when we're not at work.
Even something small like having a T-shirt on under your shirt that has a slogan that supports a political party or a movement, whether it's, you know, ecologically oriented or political party oriented or pro or against a religious group or affiliation. I just always recommend try not to have any writing on your clothing wherever it is that you go. It just keeps the conversation from going there, and it keeps you clean of getting engaged in things that people have very strong feelings about, and the encounter or the situation that you're in, whether it's rehab or admitting or discharge or anything in between, doesn't have anything to do with who's running for president or whether or not we should be digging the tunnel or any of the things that have come up for me when I've interpreted in the past. We want to really be focused on the patient and getting them to trust and communicate well with their provider. So let's not add any fuel to the fire, or let's not give an opportunity for someone who doesn't want to talk about their health to find an out and say, oh, I see you're wearing a pro-this or an anti-this shirt, and get into a discussion with you. All right, non-discrimination. So here's the big one that Title VI covers. Under Title VI, gender, nationality, country of origin, all of these things are protected under law and provide under country of origin the ability to offer language access services to people that are limited in their English proficiency. So what are the nationally protected classes here in the United States? Your gender identification, whether you're able or disabled, your race, your national origin, age, socioeconomic status, educational attainment, your marital status, your religious or political beliefs, and sexual orientation. All of these things are protected, which means you can't discriminate against people who belong to one or more of these classes and say, yep, we take all the white people who want to come and watch this movie, but we're not going to let any non-whites in. That went away with Jim Crow, and all of these other classes are the ones that are protected here in the U.S. Characteristics, on the other hand, are not nationally protected classes, but characteristics are important, and here are some of the ones that interpreters need to be careful to not discriminate against. People from ethnic groups or affiliations that have been in opposition to the interpreter's own ethnic group or affiliation. People who have been incarcerated in the past, which means in jail, or who are presently incarcerated. If you work or take assignments at Harborview, that's where our inmate population gets treated. If you work or take assignments at UWMC, that's where our inmate population gets treated. Another class of people that have had to endure discrimination and that don't often get the quality of interpreter that they need are people with specific medical or mental afflictions, whether it's HIV positive or a lockdown unit in a hospital. Those are harder to fill, especially if it's a language that you don't have on staff and that you need to go to agency for. People who have made life decisions that the interpreter does not agree with. It doesn't matter whether the patient chose to be transfused, chose to terminate a pregnancy, chose to end their own life. If it's legal and offered in the hospital or medical center, it doesn't matter whether you agree with it or not. If you don't agree with it, you don't do it for you. But you don't get to make that choice for someone else. And that someone else still needs to ask questions and understand the answers and be able to communicate in both directions.
So here's a quiz. The interpreter arrives at an assignment and finds out the client is an elder from a part of the community which has very strong religious beliefs that are opposite to the interpreter's personal beliefs. The interpreter's first impulse is to leave the encounter and not ask to be paid. This interpreter is not happy about having to interpret for this patient. He wants to bolt. The interpreter should, A, greet the patient just as he would any other patient. B, avoid the opportunity for personal discussion between himself and this patient. C, let the receptionist know that he, the interpreter, is not one of the religious affiliates of the patient, that he, the interpreter himself, has modern views. D, the interpreter should interpret for the patient, paying great care to listen carefully to the meaning from the patient and from the provider, and to transmit it faithfully. What we want to do is provide equal care to this patient. That is what our Code of Ethics tells us that we need to do. So we will, A, greet the patient just as we would any other patient. We will avoid the opportunity to get into a discussion with this particular patient. We will interpret for the patient, D, paying great care to listen carefully and to transmit it faithfully. We will not talk to the receptionist about the patient and say, hey, see that old guy over there? He's one of those religious guys. Now, I speak that language that he does, but you know what? I'm educated and I'm modern, and I'm really different from that old religious guy over there. We are not going to do C. So your answer is E, which is we will do A, B, and D. Self-representation, what does that mean? It means what do we tell everybody around us about our credentials? It is very clear. We need to be very honest and clear and direct about what our credentials are. Are we certified? What kinds of certifications do we have? Are we certified as a medical, court, social services interpreter in the state of Washington? Are we nationally certified as a medical interpreter or a court interpreter? Are we a conference interpreter? We need to be clear. It's very good to say that we have been providing service as that type of interpreter for so many years, or that we specialize in a particular type of medical or social interpreting. For example, I specialize in mental health interpreting, or I specialize in vocational rehab interpreting, or labor and industries interpreting. It is ethical, it is necessary for us to correct any mistaken idea that patients or staff have about our qualifications. So, for example, we want to make sure that we say that we are an interpreter. We know that an interpreter is different from a translator. A translator has different skills in taking a written document and turning that into a written document in a different language. That is a different set of skills from being an interpreter. We do not want anyone to get the impression that we are also a translator if we are not a translator. If we haven't been trained and certified and qualified to be a translator, we should not let people call us a translator. We need to correct them and say, actually, I am an interpreter, and these are my credentials. I am not a translator. We have to be very careful that if we speak more than one language, that we're very clear about what we are actually certified or qualified to interpret in. For example, if I learned Cantonese from my grandmother, but I did not go to school in Cantonese, I have never done adult Cantonese language, just childhood Cantonese language, I should not ever interpret in Cantonese. I should interpret in Mandarin, which is my certified, qualified, fully adult and professional language.
And Linda, I just want to say one thing about the difference between certified versus holding a certificate because you completed a training course. For example, Bridging the Gap, which is an excellent foundational beginning training course for medical interpreters, gives you a certificate of completion. Having a certificate does not make you certified. Taking the LTC exam, written and oral proficiency, is what obtains the DSHS certification, which is a whole nother animal from a certificate of completion.
And it gives you privileges.
Absolutely. And there's a lot of confusion around those two words, certified versus a certificate holder, that I want to see go away. The certificates are great, and I salute everyone that holds more than one certificate of training that was completed. But it's the certification that gets you into the door of the large medical centers, because they're not accepting uncertified healthcare interpreters any longer.
Right. The certification is the professional qualification that everyone recognizes to mean a certain thing. And on that same track, as interpreters, we get asked a lot for advice, for example, on what kind of insurance should my family get? What kind of medical insurance should I get for my family? In order to give advice on what kind of insurance to buy, in the state of Washington, a person needs to go through a certification process in insurance specialization in order to give advice to anyone else outside of his own family about insurance. I am not allowed to give my staff or any of my friends advice about insurance, what insurance they should buy. I can say, hey, I bought this, but I need to be very careful to not let somebody else think that I have qualifications to advise them on something, for example, on insurance. So we must be very careful as medical interpreters when we get questions to say, it sounds as though you have questions about this. I am not qualified to provide any information on that topic. We can ask the people here who they could recommend you talk to about this, who is qualified to provide you with information about it. So here's a quiz, and it's based on a true story. There's an interpreter who has a reputation in the community as being very wise. This interpreter has worked at a major hospital as a staff interpreter for many years. Many call him doctor out of respect, as he is willing to listen to their health complaints and give them advice on when to go to the emergency room. And this interpreter was getting calls from people in his community. So this wasn't while he was on the job that he was giving advice. This was just when he was at home and people would stop by and say, you know, my hip is really aching up, giving me a lot of problem, or I've had a headache for 3 days. What do you think I should do? And this interpreter would at times say, you know, it sounds pretty serious to me. If it were me, I would go to the emergency room. And he wasn't giving medical advice. He was giving advice as a friend who had some experience with healthcare. And people really respected him for that. And they called him doctor kind of because in his community that was a way of respectfully saying, well, this guy gives good advice. But if he's in the hospital taking care of a patient as a medical interpreter, if he's at work as an interpreter and his patient says, oh, hi, doctor, I'm glad you're my interpreter today. So glad that you are my interpreter. And there's an actual MD who overhears this. The interpreter must immediately correct the community member and explain to the doctor transparently, saying, I'm not a doctor. I know you, patient, call me doctor, and many others do in the community because I like to help out when people aren't feeling well, but I'm not a doctor. And your doctor today is Dr. So-and-so, who's here in this room, and I will be your interpreter. That is the ethical thing to do. So that would be A.
Impartiality. Many of these aren't always as easy as it sounds when you read the definition. I'm going to read through this definition and you're going to say, but wait a minute. So let me get through the definition first. So the interpreter should not interpret for an individual if the individual would feel embarrassed or constrained by the interpreter's knowing about the situation. Remember, we discussed somebody that your kids both go to the same school, or you serve on a committee together, you're not friends, but you run into each other, they might feel more comfortable with somebody else. And the interpreter should not interpret for anyone if their own strong feelings about the patient or client might get in the way of attentive, accurate, respectful interpretation. And you're like, wait a minute, you just told me my feelings and my traditions or my religion aren't allowed to get in the way. Now you're telling me I should not interpret if these things are getting in the way. What are you saying? It's a very thin line, but let me try and separate it out for you. Imagine you yourself are a rape victim, particularly if it has occurred somewhat recently as opposed to 10 or 20 years ago, although I would imagine it always stays with you. And as a recent rape victim, you are called to mental health clinic where someone is suffering from night terrors or depression or something related to the fact that they themselves are a rape victim. Sometimes, because we use that first person, I felt this person hurt me like this, sometimes the patient's story, when it so closely mirrors a traumatic event in your own life, can make it impossible for you to interpret because you may become emotional, because you may start crying, because you may have a panic attack. If you are a female interpreter who recently miscarried a baby that you were very much looking forward to having, and you are called to women's clinic and you need to inform a heavily pregnant woman that her baby has suffered a fetal death, or even to tell the mother of a baby that they've been diagnosed with something incurable and they have a limited amount of time in this world, that might be beyond what you're able to do because your own emotions, your own psychology shuts you down. That's different from choosing not to interpret for someone because you don't approve of their religion, you don't approve of their lifestyle. That's more of a choice as opposed to reigniting your own trauma and revisiting your own trauma in a way that makes it difficult for you to communicate. If I'm crying, if I'm suffering a panic attack, I'm unable to carry that message back and forth, even if I very much want to. Even if I identify in a way that says, I wish somebody had been there to be able to support me in telling this story. But it does no good to add the burden of your pain onto the patient that has just been assaulted or suffered a traumatic event of being informed that their child is going to die or their baby died in utero. So there is a very, very thin line of difference, and what it has to do with is choice. If it is something that is beyond your control because it is too fresh an injury for yourself, you have to, and the word is, recuse yourself from the assignment because you are unable to live up to the standard that you yourself strive for every day. That's very different than saying, he voted for the wrong guy, I don't want to interpret for him.
In fact, I think if we look at our quiz, this is a situation just like that.
So the impartiality quiz, here's your scenario. The interpreter has many relatives who are not yet accustomed to all the differences of the American system of health care when compared to their own country of origin system of health care. These relatives need a great deal of encouragement to disclose their symptoms and a lot of explaining to understand their condition and what they must do for self-care. The interpreter is not the intimate caretaker for these people, however, and there are plenty of politics within the family. When the family members insist that a certain person be their interpreter instead of the interpreter, what should the interpreter do? A, go with them to their appointments as a family member only. B, tell them that the interpreter will go with them the first few times, but after that they'll need to start accepting other interpreters, knowing in their heart that they're never going to accept anyone else. C, make an excuse every time so that the interpreter doesn't have to accompany the family members, leading them to think that he is shirking his family duty. Or D, educate the family that professional interpreters are completely discreet and that the clinic will provide an interpreter to them for free. Well, if we look over those answers, two of them look more ethical than the other two. Making an excuse every time and sort of dodging the bullet does not sound like a open, transparent way of dealing with this situation. And telling them that you will accompany for the first few times, but after that you'll need to start accepting other interpreters is only a half solution because you're still encouraging them to start off doing it the wrong way, which is using a family member as the interpreter. So what's needed is a little bit of education for them to come to trust the system. and also your support, but as a family member, in your role as a family member. Let somebody else do the heavy lifting of the interpreting, particularly when emotions are involved. Just as we were discussing prior, when you have a traumatic event that mirrors what you're interpreting and your emotions come up, it really adds to the number of mistakes that you make, the number of hesitations you have, the uncertainties. You don't come across as smooth, you don't come across as professional. We want every patient to have the smooth, professional interpretation at a high level of skill every time, not most of the time. And we don't want to deny the family the presence of a family member that can then reassure them afterwards, yes, I was paying attention and that interpreter did a great job.
And as a family member, we can't be impartial because we have an agenda for every family member, especially if we're more knowledgeable, we understand science better, we know the options better. We kind of have a plan for that patient who's our auntie or our mom or our brother's daughter. We have a plan for everybody because we like to kind of make the world come out the way we want to. So how can we be the interpreter for our family? We cannot be impartial. So, yep, we'll go as a family member, and we'll educate them how to accept other people as their professional interpreters.
So the answer is E, both A and D.
Professional demeanor. What does demeanor mean? It means behavior. How do we present ourselves? So, professional presentation. This is part of our Code of Ethics in the state of Washington, so it's pretty important. We need to show up because we're the communication bridge between the parties in healthcare or social services. As the bridge, we need to be professional. And these are the elements of being professional as a medical or social service interpreter. This is what is expected of us every time, every single assignment. We need to be punctual and organized. We need to be prepared for the material that we are going to have to talk about. We need to be prepared for the environment of the encounter. We need to dress safely and respectfully for that setting. We must avoid distracting or calling attention to ourselves by any personal activity, by comments that we make, or by having needs. For example, if we are eating, if we are drinking, if we are on our phone, if we are texting, if we are distracted, if we are not making eye contact, if we are making extraneous comments, anything that we bring to the setting has the potential of being distracting. And the healthcare setting or social services setting is about the patient or the client. We should not add any of our personal stuff to that setting, except for a professional smile, making eye contact. We can be reassuring just by the fact that we sit there in a professional way. We came on time, and we look like we know what we're doing. And, of course, we adhere to the Code of Ethics, which is what we've been talking about today. Here's a quiz. Common complaints about medical interpreters from patients or clients include the interpreter was on time. Do we get complaints about that? The interpreter was cold and rude and acted superior or uninterested in the patient. Do we get complaints about that from patients or clients? How about the interpreter was inappropriately dressed? Or the interpreter was on the phone before or during the encounter? Do people complain about the interpreter was inappropriate in conversation while waiting for the doctor? So what do you think patients and clients complain about? They don't complain that the interpreter was on time. They complain about all the other things. Rudeness, acting superior or uninterested, inappropriate dress, on the phone. inappropriate in conversation while waiting for the doctor. Lots and lots of complaints. So why do you need to know about that? Forewarned is forearmed. You want your patients and your clients to think you're a very professional interpreter. Make sure that none of these complaint items come up for your patients or clients.
And I'd just like to add to the appropriate versus inappropriate forms of dress. The one that most obvious comes to mind is being dressed in too sexual or provocative a manner. But that doesn't happen nearly as often as some of the other things, like the gentlemen who wear lots of cologne or the ladies who drown themselves in perfume. Most hospitals, especially any hospital with a critical care unit, is going to be a scent-free area. Now, I love my Chanel No. 5, but for the 7 years that I worked at Harborview Medical Center, I did not wear perfume when I went to work. It should be closed-toed shoes for everybody. And ladies who like to wear lots of bracelets and bangles and jingles and jangles and chains and things, no. The noise is distracting. Even if you're doing the right thing, you're taking notes in your encounter. You're moving your hand. It makes that jingle jangle and it gets in the way. If you're on the phone or on the video, it's much louder than anything that you're saying. So it's just being mindful of wearing somewhat serious, toned down, professional-looking office or business attire that helps you build that professional demeanor that we're all looking for.
Mm-hmm. Amen to that. So what kind of complaints do medical providers or DSHS staff make about medical interpreters? Do they complain about the interpreter had to be prodded to interpret? The interpreter lacked focus, wasn't paying attention. The interpreter wandered away and took phone calls inappropriately. The interpreter was very good at working with shy clients. The interpreter was having side conversations with the patient and family. The interpreter did not inspire confidence because of frequent hesitations. The interpreter engaged the care team to talk about his or her own health problems. Well, I'll tell you, medical providers and DSHS staff do complain about interpreters, and the only thing that they do not complain about is an interpreter who was great at working with shy clients. Providers and staff really appreciate that when interpreters are good at working with shy clients. But they sure get annoyed at interpreters that have to be prodded to interpret, who are not paying attention, who are on their phone, who can't be found when they're needed. They were there, but now where are they? Side conversations. I've heard so many times the nurses and doctors call me and say, I don't want that interpreter to come back here because every time I turn around, she's having a conversation with the patient or family, and I'm not talking to the patient, so I know that they're not interpreting for me. I don't know what they're talking about. And then I have to wait for them to talk so I can talk to the patient. And then interpreters who engage the care team to talk about their own problem or who talk to the social services workers to bring up their own family members' problems and questions, that's absolutely inappropriate and it's very unprofessional. So the answer here is all but C.
Scope of practice. And we talked about this probably, I think, on the very first slide. And another way of saying scope of practice, or another way of looking at it, is what's inside the fence? What is within my scope of practice? And what is clearly outside the fence? And the fence is what you'll often hear referred to as boundaries. Where is that line? What is mine and what isn't mine? So let's look at what's outside the fence. Interpreters or interpreter translators must not, that means never, counsel, refer, give advice, or express personal opinions to the individuals for whom they are interpreting or translating. Interpreters and translators must not engage in activities with clients that are not directly related to providing interpretation or translation for DSHS. Interpreters and translators must not have unsupervised access to DSHS clients, including but not limited to phoning clients directly, other than at the request of the DSHS employee. Interpreters and translators must not market their services to DSHS clients while on the job, including but not limited to, which means everything that we list plus other things that could fall in this list. So, arranging services or appointments for DSHS clients in order to create more business for themselves, or transport, give a ride to DSHS clients for any business, including social service or medical appointments. And this is one reason why when you have a face-to-face encounter with a provider and a patient, that I strongly recommend that you not allow yourself to be alone with the patient. Don't sit next to the patient while you're waiting to be called into the exam room. I always used to bring stationery and something to read so that I could either be writing busily, who knew it was a letter to my grandmother in Brazil, or I could be reading attentively so that I would not be interrupted. That's when people start telling you all of their symptoms and what's going on and why they came to the hospital. And then you are faced with the most embarrassing moment when you get inside and the provider says, "So what brings you to the clinic today?" And the patient turns and says, "Tell them what I told you outside." It just makes it seem like you were soliciting that information, even if you weren't, even if unasked they came and unburdened themselves with you. Or if the provider steps out and says, "I'm just going to get this form," or "I'm just going to get the attending to review my recommendations before I give you the prescriptions," or any of a myriad of other things that they could say as they say, "I'll be back in 2 minutes," and it could easily turn into 20. When the provider steps out, I step out. Because otherwise, that patient's going to turn and say, "That doctor looks younger than my grandson. Is he really a doctor? Is he any good?" Or they'll ask your opinion. "Do you think I should really go through and have this procedure, do this treatment, have this surgery?" And you're stuck with a question that you shouldn't be answering. So it sounds almost a little excessive if the provider gets up and leaves to go do something, you also get up and leave, and you're like, "Oh, that's rude. I don't want to abandon my patient." But it does not allow for that door being opened of the patient asking you for advice, asking you for recommendation, asking you for an alternative treatment, or any of the things that they regularly do. So if the doctor steps out, you step out. If you arrive early and the patient hasn't been roomed yet, try to find something to do, try to sit in a separate area. Make sure that the MA or the clinic staff or the person at the front desk knows that you are an interpreter and what language you interpret for, and then wait for them to call you over when the patient's ready to proceed.
Sometimes we can't sidestep completely. So what we want every medical interpreter or social service interpreter to know how to do is how to answer these questions in a way that's professional, that supports the patient by saying, "You are important, but I'm not the person who's going to answer that for you." Those are the messages that we want to give. You are important. I'm so glad you're taking care of yourself. That sounds like a really great question to ask. The person who can answer that question for you may be this person. Let's check with that person first. So, would you like me to remind you to ask that question, for example? Because that gives you permission to bring that back up later when that person is available to the patient.
Something else that helps you stay clear of these kinds of situations when your opinion is being solicited, when they want your guidance, is to try and avoid over-familiarity with patients and family members. And that's not easy, particularly if you've been accompanying a patient with a chronic and debilitating condition over weeks, months, years even. You come to know a lot of that patient's backstory and some of their family, extended family relationships. It's very difficult sometimes to not become an quote-unquote official family member because many families want to adopt you in. But having the script to redirect the conversation or the question to the correct person keeps you from being in that difficult spot of like, oh, now what do I do? How do I gracefully get out of this and not give them the answer they're looking for without making it seem like I'm abandoning them or not interested in their concern? So that's a great tip, Linda.
And we can also always validate your patient or your client and say, I'm so glad that you made it in today. I'll be very happy to be your interpreter today. That validates the patient. It tells him that you think he's important and that his business is important. One of my tricks and tips for getting out of a difficult conversation that you can see happening, if you can see it developing, you can see it coming, the person is making more and more intimate comments to you. Sometimes you may sit across the other side of the waiting room and they follow you. So at that point, you use this tip. You pretend that your pager is going off. And you make it, you say it in a very professional way, and you say, I'm so sorry, I must excuse myself for a moment because I have been waiting for a page to tell me about my assignment at the surgery at a different facility later today. Everybody will respect that, and it lets you get up politely and remove yourself without anybody losing face. It's not saying something else is more important. Oh, I have to take an important phone call. No, it's I've been waiting for this call because it will give me my instructions for my next patient who is also important. And I'll be right back with you as soon as they call us in. So use that.
It's tricky because you're trying to make sure everybody feels respected.
Exactly.
That everyone's communication is valuable. And sometimes people won't accept the redirection. So that's a very elegant way to remove yourself from the situation. And like you said, nobody feels diminished, nobody loses face.
So here's our little scenario. I hope you get a kick out of the scenario. So the interpreter sits on the far side of the waiting room. The patient's wife comes over to the interpreter and says, she's so worried because her husband has had chest pain, but he's only going to tell the nurse that he has indigestion. So what should the interpreter do? A, tell the wife, chest pain is a bad sign. The patient probably has a heart condition. And the wife should speak to the nurse immediately. Or the interpreter can say that any concern from the patient or the family is important for the care team to know about. And would the wife like the interpreter to accompany her now to talk to the nurse? C, the interpreter could go over to the patient and tell him that he is playing with fire to keep important symptoms hidden and that he should go right now to talk to the nurse, as every minute might be his last. Or the interpreter could tell the wife that if it's the patient's time to die, God will take him. Otherwise, he'll be fine. I wonder which one of these the interpreter should do. Should the interpreter diagnose the condition as a heart condition? No. So A is completely out. B, validate that any concern that the patient or family has is important for the care team to know about, and the interpreter will be happy to interpret for them? Yes, that's what we want to do. Do we want to go over to the patient and say, hey, patient, you're playing with fire. You're keeping important symptoms hidden. You better go right now to talk to the nurse. Every minute might be your last. First of all, we're making a diagnosis. And second of all, we are bossing the patient around. Neither one of those is okay. And D is also not okay. We are not going to take important information that the wife just gave us about her concern and say, you know what? If it's going to happen, it's going to happen. Don't worry about it. You've gotten important information from the wife. You need to validate that it's important and redirect her to the care team or the DSHS social services team and say, they are here and ready to help you, and I will be your interpreter as you speak with them. Reporting obstacles to practice, ethical requirement. This kind of gives us one more chance to look at this very, very important aspect, which is we need to know when we're out of our depth or when we are in a situation when we should not be interpreting. So the first point is, if you doubt your own competence to manage the encounter correctly and professionally, if you lack knowledge, if you have emotional involvement, or if you are impaired in some way. Let's say you just got off a plane, your plane was delayed for 2 days, you just got in an hour before, you're so tired, you realize that you're seeing double and you really can't think well, you are impaired. You must state that to all concerned, try to help them find a replacement so that they have language support, and withdraw from that assignment. Or if you have any concern at all that if you're interpreting, that would be violating the code of ethics. It might make the client or patient uncomfortable, or the client or patient has a relationship that's too close to me as the interpreter, and therefore would be an ethics violation. Sometimes you get called to an assignment and you don't realize, because you don't know the person's last name, that the person that you're going to be interpreting for is the new pregnant girlfriend of your nephew, because you didn't know her last name. And you walk in and there's your nephew's pregnant girlfriend. They're a couple, and all of a sudden you're going to be their interpreter. If you think that the relationship between you is too close, that would violate the code of ethics. You could not be impartial because you might have an agenda for them. Then you must disclose that to everyone transparently, maintain good professional relationships with everyone, assist in finding language support, and withdraw from that encounter. So we've actually gone over a situation similar to this earlier in the orientation, in which the interpreter arrives at an encounter to realize that the interpreter is going to have an emotional reaction. And we've gone over the different choices. I'm going to read through them really quickly. The interpreter realizes she's not going to be able to interpret properly. She realizes it's critical not to add any pain or embarrassment to the patient. She quietly uses the interpreter voice to say to both the patient and provider that she must excuse herself because she is not sure that she can do a good enough job of interpreting, and she will stay until another method of language support is arranged for. She validates that what the patient and doctor will talk about is very important, and she wants to make sure that they have the best services of an interpreter who can properly concentrate on the topic. What she does not do is create drama and run out of the room and pretend that she has a migraine headache and that she needs to go to the emergency room, because then she has taken all of the attention of the situation, and that needs to stay with the patient who has a very serious situation to talk about with the doctor.
So this is a lot of material, and I'm glad that it's going to be archived, because you may want to listen to this more than once as you work on each of the ethical the last one, and this is a lifelong endeavor, and it's one that you're never ever done, because it is to continually work on your professional development. Professional development is part and parcel of the ethics. We never get to the point where we know everything. We always have something more that we can learn. We always have one skill out of that group of skills that isn't as good as some of the others. There's always something we can do to improve. So the first step for deciding how to improve is assessment, and self-assessment is the most important, because that's the audience you need to sell. You need to decide, I'm just not up on technical computer terminology. And more, so much, whether it's paying the bills online or finding an app that automatically checks my glucometer numbers, or many things have changed in the way in which we communicate. We need to stay up to date with what's going on in our countries of origin. We need to expose ourselves to the way language, which is a living thing, has continued to evolve. New slang expressions, new tech talk, new societal phrases, styles, interests, because it's only going to help us interpret and do a better job for our patients and clients. Then we need to also know what our current knowledge gaps, separate from knowledge of our country of origin, are. Am I as computer literate as I would like to be? Do I have good medical terminology, or have I noticed that I am struggling to find equivalent words when it is a genetics counseling appointment, or someone who's taking chemo and radiation and I'm not up with all of my oncology terminology? There is ever increasing amounts of training available for medical interpreters, locally, through notice, through individuals that offer training. Online, there are an abundance of training classes. Schools ranging as far as Walla Walla Community College or Highline College or Bellevue all have programs in interpreting and translating, and Highline and Walla Walla have programs that are specific to medical interpreter training. Many of the courses that are available, even if they are as far as a place like Walla Walla, require your presence 2 days out of the semester, and the rest can be done online. There are national organizations, the IMIA, the International Medical Interpreters Association, and the NCIHC, the National Council on Interpreting in Healthcare, all of whom, when you go to their site, list state by state all of the trainings online and in person at community colleges and universities that are currently available in the U.S. There is an abundance of training out there. You just have to figure out, what do I want to learn first, and go sign up for something. And then there's the actual mechanics of the interpreting that are separate from the terminology, that's separate from the ethical standards or standards of practice, but is actually doing this. How do I do this better? How do I retain more things in my memory? How do I listen better? Active listening, agile listening. There are subjects that are taught, and you can find training and pursue that to increase your memory, to learn how to take notes better, quicker, more efficiently, to learn how to intervene and manage flow, to de-escalate a conversation that's getting emotional and angry and non-productive. But you have to take that first step and look in the mirror and figure out, either one, what do I need, or what would I like to learn? And start there. As we all know, DSHS is now going to be requiring continuing education units to keep your certification or authorization in good order and good standing. We're here to help you find that training. This is the reason why we're putting this online. Let's open the door to the next chapter in your life where you will continue to meet good trainers, meet more colleagues, share stories, be they war stories or success stories, learn from each other, and learn from that material online. It's a great big world out there, and there's lots of people who are interested in getting to be as good as they can and better than they currently are as healthcare interpreters. And I welcome and hope that you will join us, and hope to see you there soon.
Hope to see you there too. Hope to see you there too. So here's just a little quiz about professional development. The interpreter receives a steady stream of solicitations from agencies to interpret. They're calling them all the time. Please come and interpret for us. Actually, it's a her. No one ever checks her specific knowledge of encounter topics, assuming that she is interpreting accurately and completely. This interpreter should, A, spend all of her time doing assignments, as that helps the most people in the community. Or, she should keep a log of every instance in which she had trouble understanding the content of a conversation. Or, she should stay away from interpreting classes because that would let everyone know that she has more to learn. Or, she should target the areas in which she has identified deficits in her knowledge or skills and take classes in those topics. Now, the answer is that she should do 2 of the above and she should not do 2 others of the above. But which 2? Let's look at these. If she spends all of her time doing assignments, she's not going to have any time to do classes. So that's not good. She needs to do professional development. It could be reading a journal, like a scientific journal or a medical journal, or Psychology Today or something like that. It doesn't always have to be a class. But if she's spending all of her time work, she's not going to have time to do professional development. So A is not a good idea. B, keep a log of every instance in which she had trouble understanding something. Aha! Now she's identifying the gaps in her knowledge. She definitely needs to do that. The best interpreters that I've ever seen have a notebook that they carry with them every single day, and every day they add terms or concepts that they need to look up after they go home. And then they follow through on it. C, the interpreter should stay away from interpreter training classes because people would get the idea that she still has more to learn. Well, she should not stay away from interpreter training classes. All of us need to go to interpreter training classes all the time. And in my experience, the more proficient professional interpreters are the ones who do show up in classes, because they're not afraid what anybody thinks, and they know that there's always more to learn. And targeting the areas in which she has identified deficits in her knowledge and taking classes in those topics is exactly what we're hoping everybody will do. So again, as Eliana said, we welcome you to our classes, and we look forward to seeing you there. So as a review, the DSHS Interpreter Code of Ethics governs role boundaries and expectations for behavior and performance of medical and social service interpreters. The interpreter must be prepared for the work, initially and continuously. When you start being an interpreter, you have to be prepared, and you need to continuously become more prepared. You need to be accountable for the product that you are delivering. You need to be complete and accurate. You need to practice cultural awareness and support of patient and client values and needs. You need to protect patients and clients from financial predation by yourself and report it if anyone else is doing it. it is very important to protect the patient and client from inappropriately mixing with the interpreter during social and healthcare interactions. It is not okay to mix social and professional interactions for interpreters. And we need to protect patients and clients from control by interpreters, which is why we do not solicit business. We do not suggest appointments that are good for our schedule. We do not give advice of any kind to our patients, even if they ask us for it. Here is the contact information for the Language Testing and Certification Program. You are invited to use this material in any way as long as it is not commercial.
Thanks for joining us today, and I commend all of you who have come to attend this webinar and start your journey on bettering your delivery of service to your community and to healthy outcomes for all. Thanks so much for coming today.
Thank you.